Most basal cell carcinomas are highly curable, but their treatment should still match tumor risk rather than follow a one-size-fits-all rule.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Okay, so we hear the name basal cell carcinoma, and it's super easy to assume every single case is the exact same problem. But practically speaking, when you're actually looking at a patient, how do these tumors differ from one another when it's time to decide on a treatment?
Honestly, they can be completely different surgical worlds. I mean, consider a straightforward 6mm nodular tumor sitting on someone's back. Now compare that to a recurrent, infiltrative tumor on the side of their nose. Yes, they share a diagnosis, but they absolutely do not share the same margin problem, the same recurrence risk, or the same optimal surgery. Think of treating basal cell carcinoma like choosing the right fire extinguisher. A little candle flame and a massive kitchen grease fire are technically both fires, right? But if you treat a recurrent nose tumor exactly the same way you treat a small back tumor, that is how a completely manageable problem turns into a total disaster.
So, the safest plan always has to begin with classification. When we're classifying a tumor, we're looking at factors like size, the clinical borders, and its treatment history. But location? Location deserves some serious emphasis here. A 7mm tumor on a tissue-sensitive central facial site, we're talking the nose, the ear, the eyelid, has infinitely less spare tissue to work with. It also carries much greater reconstructive consequences than that exact same 7mm measurement on the back. Millimeters just matter differently depending on where you are. And beyond just the location, we have to look really closely at the biopsy pattern. While some patterns are low risk, others, like infiltrative or morphiform types, are incredibly aggressive. They don't grow like a neat, predictable little marble. They behave much more like roots spreading through soil, growing in these thin strands or irregular microscopic extensions way beyond what you can see on the surface. That makes it incredibly easy for a surgeon, even taking what looks like a visually generous margin, to completely miss a narrow microscopic root of the tumor.
Wait, but does a simple biopsy actually give us enough information to know if those aggressive roots are hiding in there? Not always, and that is a really crucial point. A biopsy is just a tiny sample. It's an honest sample, but it can miss things. In fact, in one massive series of over 900 basal cell carcinomas undergoing Mohs surgery, 28% of the tumors that were called non-aggressive on their initial biopsy actually contained an aggressive component, and that component was only discovered during the definitive surgery itself.
That specific uncertainty is exactly why Mohs micrographic surgery is usually the strongest choice for high-risk, recurrent, or tissue-sensitive tumors. Mohs removes the visible tumor, completely maps out exactly where that tissue came from, and then examines the peripheral and deep edges under a microscope right there in the office. If cancer remains, the surgeon uses that detailed map to go back only to the positive areas. It's essentially a continuous real-time feedback loop, and it provides the highest possible confidence that the cancer is totally clear before anyone even thinks about starting a complex reconstruction.
And for these high-risk tumors, that mapped clearance drastically changes the outcome. Let's look at the numbers. There is a landmark randomized Dutch trial that tracked recurrent facial basal cell carcinomas over 10 full years. It showed a recurrence rate of 3.9% after Mohs surgery, compared to a staggering 13.5% after a standard excision. Think about that. That means Mohs reduced the long-term recurrence rate by about 71% for that specific high-risk population.
Okay, wait a second. If clearing the tumor is the ultimate goal here, why not just use a cream and avoid surgery altogether? Can non-surgical options just replace Mohs?
You know what, that's the perfect question to reset our focus for a minute. Because yes, Mohs is the absolute gold standard for high-stakes cases, but we shouldn't use a sledgehammer to crack a nut. Simpler options, whether they're surgical or non-surgical, are entirely appropriate, provided the tumor's risk profile actually fits.
Let's backtrack to that low-risk back tumor we brought up earlier. For a primary, well-defined, non-aggressive tumor sitting in a very forgiving location, standard excision is a highly effective, widely available choice. The doctor simply removes the tumor with a planned rim of normal skin and then pathology checks representative vertical sections after the removal. For properly selected lesions, standard excision achieves roughly 95 to 98% 5-year control. Now, addressing your question specifically about the creams, topicals like Imiquad stimulate a local immune response, and they can treat carefully selected superficial tumors. But the randomized data for low-risk tumors tells a very clear story. Surgery sits up there at about 97.7% 5-year success. Imiquad is lower, hovering around 80.5 to 82.5%. Topical 5FU and photodynamic therapy are even lower than that.
So yes, creams do avoid the scalpel, but they have lower long-term tumor-free survival and, crucially, they provide absolutely zero surgical margin assessment.
All right, what about scraping the cancer? I hear about that happening pretty fast, right in the office.
You're referring to EDNC, electrodesiccation and curettage. This involves actually scraping the tumor with a tool called a curette and then using heat to treat the base. A large nationwide Danish cohort study actually showed a 9.9% recurrence rate at 5 years overall for this method. It is definitely fast, and it's cost-conscious for a small, primary, low-risk tumor on the trunk or the limbs. But because there's absolutely no microscopic margin assessment happening, it is entirely inappropriate for a recurrent tumor, an aggressive subtype, or high-risk facial site.
Makes sense. So what if a patient is healthy, but they just flat out don't want an operation? Is radiation an equivalent alternative? Look, radiation is vital for patients who physically cannot undergo surgery or who decline it after a really thorough, informed discussion. But for a healthy, operable candidate, the direct randomized evidence heavily favors surgery. An older randomized trial comparing the two found a 7.5% recurrence with radiation versus just 0.7% with surgery. Plus, the surgical group had far better cosmetic outcomes. Radiation requires multiple visits, it carries the risk of late tissue effects, and it generally shouldn't be treated as just a simple convenience equivalent to margin-controlled surgery.
And then, in some very specific, nuanced cases, the absolute best medical choice is to literally just watch it. Observation isn't denial. It is a deliberate, competing risk decision. For an elderly, frail patient who has a limited life expectancy and a low-risk tumor, the burden of treatment might actually outweigh the harm of a really slow-growing cancer. In one prospective cohort of older patients, 53.2% of low-risk basal cell carcinomas remained entirely stable or even decreased in size during the observation period.
Now, on the absolute opposite end of the spectrum is locally advanced or neglected disease, like a tumor that is actively invading deep structures. This is a narrow pathway that requires serious multidisciplinary planning. It often involves systemic therapies like hedgehog pathway inhibitors or PD-1 immune therapy. But we have to be real here. These drugs have significant toxicities. Preventing a straightforward tumor from becoming advanced in the first place through early risk-matched local treatment is always the far better strategy.
So let's tie this whole shebang together into a practical decision framework by contrasting our two opening cases one last time. For that 6mm nodular tumor on the back, standard excision, or even EDNC, is an excellent, highly proportional fit. But for that recurrent infiltrative tumor sitting right on the nose, Mohs surgery is the clear, definitive answer. The ultimate goal isn't to pick the fanciest treatment name out of a hat. It's to use the least amount of treatment that still reliably matches the tumor's risk and provides the exact right margin strategy. If you're currently navigating this diagnosis, the single most important next step you can take is to actively discuss your specific treatment plan and margin evaluation with your dermatologist. To explore these concepts a bit deeper, I highly recommend reading the full guide, Low Risk versus High Risk Skin Cancer, available over on Skin Trust. But honestly, getting clear margins raises one final, absolutely crucial question. Once a high-risk tumor is completely cleared, what is the safest, most effective way to physically repair the skin? We're going to cover exactly that in our next Skin Trust Explainer on facial reconstruction.
Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together.